Hello doctors, welcome to the new episode of our A to Z series where every day alphabetically we discuss one of the most repeated previous year topics of INI-CET, NEET PG and FMGE, and our today's episode is episode N where N stands for neonatal jaundice. So let's begin. Jaundice, yellowing of the skin, sclera and mucous membrane from a buildup of bilirubin. 60% of term infants and 80% of preterm infants develop jaundice in the first week of life, typically an unconjugated hyperbilirubinemia. Screening of all infants is done in the first 24 hours of life by total serum bilirubin and transcutaneous bilirubin. The risk factors include prematurity, cephalhematoma, bruising, dehydration, male sex, maternal age more than 25, Asian or European descent, visible jaundice less than 24 hours, visible jaundice before discharge at any age, exclusive and partial breastfeeding, sibling with severe hyperbilirubinemia. Unconjugated hyperbilirubinemia, physiological jaundice, breastfeeding jaundice. Early onset, first week after birth, insufficient milk intake leads to dehydration resulting in hemoconcentration of bilirubin. Fewer bowel movements increases the enterohepatic circulation of bilirubin. Breast milk jaundice. Later onset after 1 week of life, bilirubin level peak during weeks 2 to 3 of life, can persist for 3 to 12 weeks, cause unknown. It is thought that substances in breast milk interfere with the breakdown of bilirubin. Prematurity occurs in preterm infants less than 37 weeks, more likely to require phototherapy. Management include phototherapy, continue breastfeeding, supplemental PO or IV fluids. Phototherapy makes bilirubin water soluble by inducing a conformational change. Hyperbilirubinemia is treated to prevent connectus acute bilirubin encephalopathy. Pathologic unconjugated hyperbilirubinemia can be divided into hemolytic and non-hemolytic. In hemolytic, we have intrinsic G6PD deficiency, hereditary spherocytosis and thalassemia, extrinsic drugs, isoimmune and sepsis. In non-hemolytic, we have sepsis, hypothyroidism, cephalhematoma, Gilbert and Klinger-Najar. For workup, Coombs test, CBC with differential blood smear, blood culture is done. Conjugated hyperbilirubinemia can be divided into extrahepatic and intrahepatic. In extrahepatic, we have biliary atresia, choledochal cyst, perforated bile ducts, tumor mass, cystic fibrosis and galactosemia. In intrahepatic, we have infections, hepatitis, torch, UTI, etc., drugs, and genetic metabolic. Must rule out biliary atresia. Initial investigation include abdominal ultrasound. Now let's practice a few MCQs. A neonate is born to a 32-year-old female at 34 weeks of utosic delivery. The baby weighs 2.9 kg at birth. Vital signs are within normal limits. A physical exam of the baby after 12 hours of birth shows that soles and palms are yellowish. Pressing the skin down with fingers increase the yellowing. What is the probable bilirubin level in the neonate? Option A 6 mg per dl, option B 9 mg per dl, option C 12 mg per dl, option D 18 mg per dl. Which option do you think is the correct one? Well, yes, option D 18 mg per dl is the correct option. Jaundice is a common condition in babies born before 38 weeks of gestation period. Visual assessment of bilirubin level is performed by modified Kramer's rule. In this rule, the baby's body is divided into 5 zones. Zone 1, the face, 4 to 6 mg per dl. Zone 2, upper trunk, 6 to 8 mg per dl. Zone 3, lower trunk and thighs, 8 to 12 mg per dl. Zone 4, arms and lower legs, 12 to 14 mg per dl. And Zone 5, palms and soles more than 15 mg per dl. The next question is, which mechanism in phototherapy is chiefly responsible for the reduction in serum bilirubin? Option A, photooxidation. Option B, photoisomerization. option C, structural isomerization, and option D, conjugation. So which option do you think is the correct one? Well, yes, option C, structural isomerization is the correct option. Structural isomerization. Bilirubin is converted into lumirubin, which is excreted through kidney without conjugation. It is faster and irreversible, the most important mechanism by which phototherapy acts to reduce serum bilirubin. Our next question is, a newborn develops yellowish discoloration of skin which is more towards the limbs compared to the face. On evaluation, the bilirubin levels on soles is 14 mg per dl while on the face is 6 mg per dl. Which part of the brain is most commonly involved in neonatal jaundice? Option A, thalamus. Option B, hypothalamus. Option C, lateral ventricle. And option D, basal ganglia. Well, yes, option D, basal ganglia is the correct option. Neurological manifestations. Most commonly involved part of the brain in neonatal jaundice is basal ganglia. Type of cerebral palsy seen, extrapyramidal type. Kernictis, yellow staining of basal ganglia, previously used term. The next question is, a newborn was delivered by LACS. On the second day, he developed yellowish discoloration of his hands and feet. The pediatrician advised phototherapy. What is the most effective wavelength of the light used in phototherapy? Option A, 460 to 490 nanometers. Option B, 360 to 390 nanometers. Option C, 420 to 440 nanometers. And option D, 400 to 440 nanometers. Well, yes, the correct answer is option A, 460 to 490 nanometers. Most effective wavelength of light used is 460 to 490 nanometers. Mechanisms by which phototherapy act. First, photoisomerization. Bilirubin converts into polar compound which is excreted through kidney without conjugation. This is slow and reversible. Second, structural isomerization. Bilirubin converts into lumirubin which is excreted through kidney without conjugation. It is faster and irreversible. And third is photooxidation, which is the least important. Measured using flux meter. Effectiveness of phototherapy depends upon exposed surface area of baby. Distance between baby and phototherapy unit 30 to 45 centimeters. Type of lamp used, LED lamps is more preferred than CFL lamps. So the last question for today is, which of the following is the most common cause of neonatal jaundice? Option A, hereditary spherocytosis. Option B, G6PD deficiency. Option C, polycythemia. And option D, hemolytic disease of the newborn. Well, yes, option D, hemolytic disease of the newborn is the correct option. The most common cause of neonatal jaundice is hemolytic disease of newborn or erythroblastosis fetalis. So that's all for today. Thanks for watching and see you in our next episode, which is going to be episode O.